This ECG shows features of left ventricular hypertrophy with strain pattern that is classically seen in severe hypertension, left ventricular outflow tract obstructions like severe aortic stenosis and hypertrophic obstructive cardiomyopathy. You can see the tall R waves in V5, V6. Here it is 3.1 millivolts or 31 millimeters in V6. Correspondingly, there will be a deep S wave in V1, that is 1.7 millivolt or 17 millimeter. If you add those together, if it is more than 3.5 millivolts or 35 millimeter, it satisfies the Sokolov line criteria for left ventricular hypertrophy. If R wave in V5 or V6 is more than 2.6, that is also suggestive of the same thing. Here it is 3.1 millivolt. Then you will see the hypertrophy with strain pattern, ST depression with T inversion in lateral leads. It's seen in lead 1 also and lead 2, and that is part of the strain pattern occurring in systolic overload. Sometimes this pattern can also occur in chronic severe aortic regurgitation, long standing. But usually aortic regurgitation is a volume overload situation and you get left ventricular volume overload pattern. That is different. So this is left ventricular hypertrophy with strain pattern, classical of obstructive lesions and severe hypertension, that is systolic overload. In aortic regurgitation, it is diastolic overload. Another voltage criteria known as Cornell voltage criteria for left ventricular hypertrophy. You take the sum of R in AVL and S in V3. Here it is total 29 millimeter. There is a difference for this Cornell voltage criteria. The cutoff is 20 millimeter in females and 28 millimeters in males. So both ways this satisfies. Regarding voltage criteria for left ventricular hypertrophy, especially the Sokolov line criteria, it can be affected by thickness of the chest wall. In thin individuals and in children, voltages will be high because heart is nearer to the chest wall.